Yeah, good evening, friends. Welcome to this Tuesday master classes. We thought the last 2 years being the pandemic, many of our physical academics gone into a halt, even though we continued the new normal of the online classes and academics. So we thought of bringing some kind of case-based discussions, which will help our students, all the DNBs, IFCCM, IDCCM, postgraduates who have been working tirelessly for the last couple of years in this pandemic. So the Yashoda group of organization, the Department of Critical Care Medicine and ICSM Hyderabad chapter felt if we can bring all the seasoned clinicians who have been a part of the examination and a part of the teachers in the ICCM exams and FNB exams and a new pattern of DNB exams. And we interact with the students in a format that they will present one case and the teachers who have been examining them previously will take them through the different question answer session. So the others will get an hands-on experience. And we initially were doing with the local teachers in Hyderabad, but later on, the last year, because of the new normal, we felt a big advantage of being this exposed to the whole of the India. And to our surprise, there were around 500, 600 students joining our webinar, taking the benefits. So this time we felt why not to invite all our seasoned examiners across the country and give this benefit to all our students across the India. So that was the motive behind this. This is particularly in the corner of students' concern. So being a student, we have gone through the same kind of difficulty and pain preparing ourselves. And now I will invite and probably introduce Dr. Pradeep Rangappa sir, who has been our Vice President of Indian Society of Critical Care Medicine and been lead clinician in the critical care department of Manipal Group of Hospitals and been one of the lead member to the government of Karnataka in this COVID task force during this pandemic. And he has been a species and speaker and examiner. I have been one of the bigger fan or a stardom fan for his all presentations, the way he presents, the way he probably puts across his slides. I'm a big fan of that. And I thank him from my bottom of the heart. In a quick time, he actually accepted our request to be the examiner for the first session. We do understand we have a gap of 15 days for the next case, but for the first case, probably we had a very short time. And I fully actually appreciate his efforts. He's being not well for a couple of days or more with ongoing pandemic, but he agreed and came across. Welcome you, sir, Dr. Pradeep
Yeah.
Rangappa, sir. It's a pleasure
Thank
for
you.
us to be you on board.
Thank you. Thank you so much, Venkat, for your very kind words. It's always pleasure to be associated with our people here to take the cause of academics in intensive care. And this is a wonderful initiative Venkat has been doing. And if you recall, we were doing a lot of this as a physical format, Venkat, in our region. I think many of us were doing independently in a physical format where we used to have sessions. We used to call it as a simulation exams prior to these DNB exams and our IDCCM exams. So now obviously physical is something which we were unable to do. So we have resorted to this virtual. But I think what we have realized is a lot of things can be attained in the virtual, but hopefully with the end of this pandemic, we should be able to start the physical sessions because especially today's session, which is meant to be a clinical case presentation for all the listeners. So exams are of varying formats, but the quintessence of every exam and the examiner and the examinee is to ascertain the knowledge base and how safe a candidate would be once he comes out of passing the exam. So how safe is he to the patient? So that would be the key essence that we would be focusing on when we assess a student, whether he is going to be a safe clinician in safeguarding the life of a patient is what any examiner would look at. And the second important aspect is intensive care. There is a lot of chaos. So seeing clarity in chaos is the quintessence of the intensive care. So as an examiner, we wish to see how you are able to prioritize your care management, how you are going to prioritize, because there's a lot of noise or chatter in intensive care. And we really see as to how you try to prioritize your care management and the investigations, be it management, be it interventions, be it communications, how would you prioritize is what we see. So for the way we would take this session, as I discussed with Venkat, is Dr. Mahesh. He's a final year DRNB, as I understand. So he would present the case, and the topic I'm sure every listener here is already aware. So this is not a typical thing that happens in exam where candidate knows what the case is, and the examiner also knows what the case is, and there is a lot of time for them to prepare. So examiner is blinded, student is blinded, case is blinded, and it is a time bound phenomena where limited time is given for student to grasp the whole crux of the issues with the patient and package it and present it. But here it is little different. So Mahesh will present the case. Me and Venkat would possibly ask questions as to how we would ask in the exam. And for all the listeners, the questions will not necessarily be only related to the topic that is highlighted today. It may be a lot of things that may surround around the issue, but towards the end of it, me and Venkat will sort of give you the key take home or the salient points that one would wish to know about the topic that we have today for discussion. So this is how the layout would be. So Venkat, anything you want to add?
Yes, I think that's the flow. So without wasting time, we will request Dr. Mahesh to actually initiate the case. I just wanted to tell all the audience, welcome you on board. And this is to help you all. This is not to test anyone. This is to help all our students, our dear students who have been working in the front line, the real core, hardcore workers in the front line. And this is a gesture what ISCCM and Yashoda Hospital wanted to give it to all of you. And the other part is all of you can put your answers on the chat box. All of you will be muted for this period. But at the end of the session, you will be allowed to raise your hand and your mic will be unmuted. So you can ask questions to our examiners so that they can answer all your queries. And till that time, because of there will be probably 200-300 students asking questions at a time. We will request all of you to put your questions in the chat box or question answer box. With this, over to you, Dr. Mahesh. Mahesh is our final year DNB postgraduate. So he will bring us the case. Over to you, Dr. Mahesh.
Thank you, sir. So, good evening, everyone. Myself, Dr. Mahesh, and I'll be presenting this case today. And this is the first case in this master class sessions program. So, coming to the chief complaints and history of the patient. So this 72-year-old gentleman has brought to the hospital with shortness of breath and cough with expectoration and edema over both the lower limb extremities. So all the three complaints are 10 days duration, and going on to each one in detail. Shortness of breath is gradual in onset, progressive with 10 days of duration, and initially it was grade 2 to grade 3 and then progressed to grade 4, and then now at the time of presentation to the hospital he was feeling distressed despite of baseline oxygen support. Because I am mentioning this baseline oxygen support, why I am mentioning is this: he was on oxygen support since 1.5 years because of his past comorbidities. And this shortness of breath is present in all postures and exaggerated in recent times, and there are no particular relieving factors for the shortness of breath. Even the oxygen supply, which was there, got increased nowadays, means before presentation, but there are no relieving factors. So this SOB was not associated with any chest pain and not varying with any respiratory efforts. The second one is cough. That was also again gradual in onset, progressive, and the duration was again 10 days, but it was dry cough, means non-productive cough in the initial period of 5 days. Later on, it has become productive with a greenish, means a greenish white mixture of color. Not copious amount, but expectoration was there. in between. So cough was not associated with any hemoptysis or body weight loss, evening rise in temperature, nothing. And then the third complaint was lower extremities edema. Actually, this complaint was again 10 days duration only, gradual onset, progressive. But the inciting event for this complaint was started 1.5 month back before his presentation. That's why I have placed this complaint in chief complaints only. So this lower extremity edema was again gradual in onset, progressive, and 10 days duration with disproportionate. Right limb was more swollen than compared to the left, and he has that inciting event skid and fall. And the type of edema is pitting type edema, and edema is not associated with any rise in JVP or palpitations.
So we will wait here. Pradeep sir, we will interact here, I think, with this complaints. So then you can unmute, sir.
Yeah, sure. Yeah, Venkat, you go ahead.
So Mahesh, can you summarize? See, if you look at this, these are only complaints with which this patient presented to you. Okay. So can you summarize 1, 2, 3? If I summarize in this way, this patient had a breathlessness which was worsened. Even he was on oxygen therapy for a longer period, but that was a baseline which worsened during the last 10 days period. And you also spoke about a cough, which later on turned to be having expectoration with the greenish coloration. Third, you said there is a swollen limb, and there is also a history of a fall, an injury. So there are the 3 major complaints with this patient came to you. Am I right?
Yes, sir.
So what are your differentials at this point of time? What is your provisional diagnosis? And why do you say so?
So, sir, sticking on to this, my patient and each complaint, for this 72-year-old male patient, the shortness of breath can be 2 systems basically originated. One is cardiovascular system, another one is respiratory system. Coming to cardiovascular system, it 72 years age, geriatric age group. So a lot more arrhythmias can happen, myocardial infarctions and heart failures, congestive heart failure with ADHF, means reduced ejection fraction, like cardiac origin respiratory means respiratory distress causes. Coming to the respiratory system origin, so this 72-year-old male and sticking on to my patient, he has a history of prior hospital admission and then skid and fall. So prior hospital admission can have the means can be there can be a chance of hospital acquired infection, community acquired pneumonia because of this pandemic, can be a COVID related pneumonia, and he has a history of skid and fall with the long bone fracture, which I'm going to discuss. So there can be a possibility of pulmonary embolism. And this patient, since the last 1.5 years, he's bed bound, so there will be chances of basal atelectasis and thereby causing ventilation perfusion and then shunt fractions. All those things are there, sir.
So was this patient recently hospitalized anywhere in the last weeks or recent times?
Yes, sir. That I will tell it in past history, sir. But anyhow, I'll mention it. Actually, this patient was affected with COVID in 2019 November, sir. 2020 November, sir. After that, he was, because of this coma means COVID sequelae, he was on continuous oxygen support at 2 to 4 liters at home, and only mobilized during the time of his.
So, Dr. Mahesh, see, when in ICU, typically the history is good, but we really do not dwell into the specifics of progressive to grade 2 to grade 4. So, looking at this history, whatever you have summarized, Mahesh, what are the top 2 differentials you have in mind? You said a lot of causes, but you would, from this history, what do you think would this patient be having in your mind as the top 3 diagnosis? What is it that you have in mind?
Patient is presented with shortness of breath, sir. So acute respiratory failure can be means with many causes. So, but this patient, sticking on this patient, will have like community acquired pneumonia, pulmonary thromboembolism, then any other infective related pneumonias.
So community acquired pneumonia is a possibility. So if it is community acquired pneumonia, so how severe do you think this patient has? Are you aware of any of the criteria for community acquired pneumonia to ascertain the severity? So you would be worried about severity in this case, or just given the history, and the age and the
at this point of time, based on the history and baseline investigation of arterial blood gas, he has a hypoxic respiratory failure, and the scores which are there to grade community acquired pneumonia are like curve 65, C clinical pneumonia, CPIS score, then other scores are there, curve 65, all those things. But here he was mainly presented. Even the pneumonia can be possibility is there, sir, but hypoxic respiratory failure is the one which I can stabilize as of now at this point.
Okay. So physiologically, Mahesh, what do you think is the pathophysiology of the differentials you're thinking? Because you said lung or heart issues, but physiologically, if we have to ascertain what may be the problem, so how would you look at trying to ascertain physiologically what may be the underlying problem with this given history? So there are a lot of physiological reasons as to why the respiratory failure sets in, isn't it?
Yes.
So what do you think is the underlying problem here in this patient from the history you've given?
From the history.
From the differentials you have given.
It could be ventilation perfusion mismatch.
So does ventilation perfusion mismatch happen in community acquired pneumonia, which you put it as a first diagnostic possibility?
No, sir.
So then what happens in pneumonia? What is underlying physiological phenomena that happens, which causes the respiratory failure?
In pneumonia, the alveolar epithelial cells will...
No. So there are broad categories of respiratory. You said ventilation perfusion mismatch is one of the category. So what about in heart failure or pneumonia? What is the pathophysiology that happens which causes the hypoxemia in these patients?
The dead space will get increased in heart failures because of congestion of the alveoli. Shunt fraction will get increased.
It's a shunt problem, isn't it? So having a shunt issue is a cause of hypoxemia in the underlying problem. So we need to be very clear when we talk about infection or a heart failure, it is predominantly the shunt problem. And ventilator perfusion mismatch, what you mentioned is for the other differential that you only gave us. So what are the other underlying physiological problems that can cause respiratory failure, Mahesh?
In hyperventilation, then decreased FiO2 means decreased fraction of oxygenation, then diffusion impairment, then this shunt fraction, then that shunt fraction VQ mismatch.
Any others? Any mixed venous oxygen issues? What if I say he has a low cardiac output? So what do you think will contribute to the cause of respiratory failure? Because he's an elderly having a COVID, severe COVID, and I think I've seen he was bedbound. You think he may have had a minute ventilation issues?
Yes, sir.
Okay. So it is important. Yeah, it is important to have a clarity onto all the underlying physiological reasons also. So, I think he can go ahead, Venkat.
So Mahesh, you initially said when this patient presented to the emergency room, you said you had 2 or 3 things in your mind. Okay, one of them you said probably he got a secondly infected, maybe a community acquired pneumonia. You said there can be a cardiovascular event like which decompensated with heart failure, or you said a embolic phenomenon. What are the important history? We are still in the history part. So what are the important history which will differentiate at least at the beginning in emergency room when you assess them?
Differentiating features means the favorable features for either pulmonary embolism or DVT things will be risk factors, sir, like age, then prior history of DVT, then any comorbidity with cancer, then any long bone fractures, major surgeries. Like these are all like provoked things which can cause and the factors which can favor for PT, means pulmonary thromboembolism. But for heart, it could, the age is the most commonest factor.
Okay.
And then the ischemic heart diseases with metabolic syndrome, means hypertension, atherosclerotic diseases.
Okay.
And then pitting type of edema, right heart failure, things like raised JVP.
Yeah, so you also mentioned that in your history. So few of your colleagues also are raising concern. How do you actually get a history of raised JVP in your history? The patients tell you that I have a raised
No,
JVP.
sir, on inspection means.
So we were in history. So I'm asking about how do you differentiate in an history? So suppose you have a myocardial infarction, you have a arrhythmia. What kind of symptoms or signs which you expect out of a patient? And then when you're talking about a community-acquired pneumonia, even though he's an elderly patient, you may have other symptoms. But what are the typical symptoms you expect in a community-acquired pneumonia? So yeah, grossly you should be able to differentiate in all of the three. Maybe none of the history may be specific to them, but this patient didn't had any chest discomfort, chest pain, any palpitation, or if that patient has any ischemic heart disease history, as you said, or a elderly age group patient. So all this, and the same way in a community acquired pneumonia, you gave a history of cough, expectoration, change in color, a high grade fever, ongoing. So all this can give you a clue that probably this patient also had a possibility of a community acquired pneumonia. And then as you rightly pointed out, this patient was having a bedridden state with a fracture in place, with a limb swollen, a high risk group for a thromboembolism. So we will come to that part in the later. But in the history wise, you should be able to make out the clinically what are the key points which you look or give you in a favor. Anyway, you will go stepwise. Then we will go to the next slide of your examination finding.
Yeah, just a quick comment, Mahesh, since there is so much emphasis on pulmonary embolism, and that's the case in discussion for today. So how common is cough in pulmonary embolism, which you seem to be mentioning with a lot of specifics about green colored sputum? Is there any report as to what are the percentages of symptomology that happens in pulmonary thromboembolism? Is there any? Yeah.
Syncope and pre-syncope will be there in 17% of the people, and the cough will be there in only 37% of the people. Okay. The dry cough means non-productive cough will be there. If at all hemoptysis is there, that can be a chance. It will be means like pulmonary infarction in the basal zones can produce hemoptysis.
So, okay, can you just enumerate the possible symptoms in a thromboembolism? 1, 2, 3, 4, commonest to the least commonest.
Hypoxia means tachypnea with
tachypnea is not a symptom. I think that's why your colleagues will say, tachypnea is your observation or a sign.
Breathlessness, okay.
Dyspnea, isn't it?
Dyspnea is the commonest.
Dyspnea is the commonest, yes.
Okay.
Because there is a published report which gives you, there is one publication by Stein et al. I'm sure you would have read that. 73% have dyspnea. And what's the second commonest symptoms in pulmonary? Because this is the case in relevance for today's discussion. What is the second commonest symptom that is reported, at least in published literature?
Cough.
Okay, I think someone has mentioned pleuritic chest pain. Yeah, that's put at 66.
Chest pain, which has been again common with your myocardium issues like even a coronary syndrome. So why do you have chest pain in embolism?
66% is pleuritic chest pain reported in the literature. These are all just variables for your own reference.
Yeah, so but these are the commonest symptoms which we anticipate or expect. So why do you get chest pain, Mahesh, in embolism? Okay, this pain is more of a inflammation due to probably the infarct area causing the inflammation to the pleurisy and pleuritic chest pain. So more of that you see a pleuritic chest pain. And then you have said cough. And how common is the hemoptysis? You give a history of negative hemoptysis. How common is the hemoptysis and cause for that hemoptysis?
Rare causes, sir, only, and cause could be pulmonary or means basal zone pulmonary capillaries means the reason for hemoptysis.
So
But it
do
will be
you mean to
rarest
say,
cause.
so how many thromboembolism are symptomatic? Do you mean to say all the thromboembolism are symptomatic?
No, sir.
So do you know what is the percentage of thromboembolism which is symptomatic? So there are a good percentage of pulmonary thromboembolism, up to 50%, which may be left alone with asymptomatically. So there is a huge horizon of a spectrum of symptoms which we go. So again, see, there are overlap of symptoms here as a cough, which is generally dry in them and more productive in case of if you have a lower respiratory pneumonia. And then, as you pointed out, pleuritic chest pain can be there in both conditions, but it is more retrosternal with a throbbing and kind of a very severe pain in case of where you see in a myocardial infarction patient. So we'll go to the examination. So we need to keep a watch on all those history findings, and you are differentiating with one to other depending on your history. Okay, next you go to the examinations.
Examination, are you talking, Mahesh? What has been your examination findings? Because that also we need to little bit deliberate as to what you would find in examination. So have you mentioning anything?
Yes,
You can
sir.
mention if it's not
So
on
you
slide.
go ahead from the past history to that slowly.
Okay, sure.
So after history of presenting illness, significant past history he has, and comorbidities like hypertensive since 25 years and on metoprolol 25 and telmisartan 40 mg, and he was means he has history of rise creatinine and diagnosed as CKD since 1.5 years with non-oliguria, and CAD got diagnosed 19 years back, and then that was posterior inferior with status post PTCA to right circumflex iliac, chronic bed bound since post COVID time, and prolonged means he is bed bound, so prolonged Carnum catheter in situ was there with recurrent episodes of UTI with the Klebsiella and enterococcus in the past 2 years, 1 year. And it means during bed bound time also he requires 2 to 4 liters since that time. And after that, this was the significant event like skid and fall in mid of December. After that, means 5 days after fall, he presented to a local hospital and got operated for hip replacement. And then now, after that major surgery, he was there in hospital for 6 days, got discharged, and then presented to our center with shortness of breath after exactly 10 days of discharge from that hospital.
Mahesh, when you look at this past significant history, what is that strikes you? Now you want to revise your differentials, or the differentials will remain the same?
One thing, CKD patient was there, so it can exacerbation means acute on chronic CKD can be possibility. Differential diagnosis can be added. Those patients who presents with fluid overload.
Mahesh, we are again re-emphasizing the history. You had given a 3 priorities, right? You said it can be a pneumonia, infective etiology, secondary infection on a COVID line. You said there can be a possibility of a cardiovascular event like ACS, and you said embolism. Now you are adding one more. So do you want to change your priority, or the priorities or the top differentials will remain the same?
No, sir, only differentials, sir. Priorities will be same.
What will be your top diagnosis now? It will continue to be your community acquired pneumonia here?
No, sir. Actually, major inciting event was there, fracture, then got operated, major surgery, history of outside hospital admission, and then now presented with shortness of breath. But the only contradicting point here is sputum with expectoration, sir, that I can expect in this post-COVID patient as a sequelae. But first priority is
so your add-on importance of or your add-on priority of embolic phenomenon is going up because of the added risk factor or the added history which you're giving.
yes.
So along with that, you say there can be a possibility of a pulmonary edema or something, or a decompensated CKD, because there is a history of CKD, so that adds another angle. And you give a history of CAD with a PTCA, so probably myocardial issues still remain to be one of them. And there is a lot of repeated infections in this patient. Can this patient also lead a kind of a device-related infection which can cause a CIRS and a early RDS?
Yes, sir. We thought of complicated UTA or urosepsis initially.
So what is the common presentations of these patients? When an elderly patient presented to you, I was also mentioning about this patient not having fever, but how an elderly patient presents to you when they actually harbor an infections?
Fever will not be there, but most commonly they will present with either respiratory distress or sensory, means altered sensorium.
So most of the times the fever may not be the initial presentation. The altered sensorium, organ dysfunction can be an initial presentation which they come, and then later on we found the source. So any questions, sir, or we'll move on?
Mahesh, now since we are talking about this topic in specific, so what is the risk for PE as you see, or a thromboembolism in this patient, and what are the general risk factors? That is one question, since the topic we need to deliberate is on PE. So what are the risk factors, Mahesh, you see in this patient, and what are the other additional risk factors that contribute to the risk? That is one question. The second question is, someone who is bedbound for how long significantly increases the risk for thromboembolism in an ICU? So that is the second question. Is there a literature reference to that as to bedbound? Is it bedbound for 1 week or 10 days or 1 month? Because here you said 2 years. So is there reference as to what is the, what is the risk proportion to the bedbound status? So can you highlight on this? And third thing, and what is the burden of this pulmonary embolism epidemiologically, Mahesh? Is it something that is common or that is uncommon?
Yes, sir. It is a third most common cause for mortality in Western countries.
In ICU?
In ICU.
Third most common cause of all mortality. Okay, so it's a third common cause of vascular cause, not a, because the first is cardiovascular, followed by stroke, followed by, this is a third vascular complication as per the US data. That's what you're trying to say, isn't it?
Yes, sir.
Okay. So now coming to the, what are the other risk factors, Mahesh, as you see in this patient?
For this patient, the risk factors are first age, sir.
Okay, good.
And then the skid and fall with long bone fracture. Okay. And then history of bedbound, means bedridden, and the significance of bedridden here is more than 3 days of bedridden is significant risk factor for
very good.
Pulmonary embolism.
I think one of your colleagues said 48 hours. I think 3 days is what has been referenced as one of the risk factors. More than 3 days, there is a substantial increase in the risk.
Other risk factors include having comorbidities like active cancer, then yes, major surgeries with general anesthesia, then other chronic respiratory failure or heart failure.
All that he has, isn't it? And Venkat did mention about something else, which is also important in these patients, isn't it? Having devices, no? Having any catheters.
Yes, central venous catheter is a risk factor for us.
Yes. Okay. Anything else?
Other risk means in acquired risk factors, other things like less severe includes diabetes, heart means hypertension, everything is a risk factor, means coming to less significant.
One
They say
important aspect I'm trying to hear, because if you look at any of the scoring criteria, Mahesh, there is very important, there's a lot of points given to one important risk factor, which I'm trying to hear from you. Someone has already messaged already in the chat. Previous history of any thromboembolic
DVT.
episodes.
Previous history.
Previous, that's
But
very
this
important.
patient doesn't.
Yeah.
Yes.
Because you said he had COVID.
Mahesh, understand the question properly. This is what happens in exam also. This is again an information to all the students. See, when a question is asked, first listen the question carefully. The question asked was, what are the risk factors for a thromboembolism? Okay. One is the patient's risk factor, which right now your patient is having. The other component is the risk factors which this patient doesn't have, but they are being asked as a, what are the possible risk factors? So this patient don't have a recurrence thromboembolism, but that is a risk factor which we wanted to know. Okay. Even a long history of hospitalization, long history of intensive care stay, which we commonly see as a common phenomenon which come across to our patients when we talk about an intensivist perspective. They also come under this. So Mahesh, now we know that there is a wide horizon of these risk factors. And now, do you have any scoring system which will predict you at this point of time? Probability scoring systems, which you know.
Pulmonary embolism, there are like multiple scores are there, and most widely accepted are the revised Geneva score and then Wells score, simplified Wells scores.
Simplified Wells score and modified Wells score. Do you know the components of that?
Modified Wells scores.
Also, do you know
Modified
the components of them?
In Geneva score, like risk factor, male sex, then active cancer, then DVT, and then underwent major surgery under general anesthesia. These are risk factors, sir. And the symptoms includes unilateral leg pain and then hemoptysis. Coming to signs means on deep pricking, if there is a pain on that unilateral pain and unilateral limb, and then heart rate 75 to 94, 1 means 3 points are there, and more than that 94, more than 94 heart rate.
Good Maheshi, for all the listeners, in exams generally we don't expect you to know every aspect, because intensive care exams are very pragmatic and quite practical. So if you know the scores available and where to look for it, because now apps are there, there are at least some 6-7 scores for the thromboembolism. So in apps you put all these variables, it will give you the score. So that's good. If you know Wells criteria,
we want you to know the components.
Yeah. So we may not really expect you to know, because this is a simulation section. You would have read everything you are answering, but in exam you may not remember what you are telling now. But at least for all the listeners here, know all the criteria that may be available, and maybe one of them you can know in a very precise way, because humanly it's not possible that I would expect everyone to remember every criteria with every scoring. So we are fairly practical in that sense. So that's the message I wish to convey. But good, you know about it, you read about it. That's good. So we can move, Venkat, to maybe the next.
Yeah. So we'll go on to the next slide.
Someone mentioned PESI in the chat, Mahesh, because I think let us make it a little more interactive, because your colleagues also are answering. So have you heard of PESI score? Are you aware of PESI score? Someone mentioned in the chart. Is that applicable as a risk factor?
No, sir. That is for prediction of early mortality and to stratify into the risk based on the risk.
Yeah, see, all these criteria for all the listeners, they have all come from some of the publications, and the PESI one was from a Dutch study. It's only come from one article. It is mainly to look at 30-day mortality risk and to ascertain that the mortality risk is low. So So it's good to know, but we don't expect you to know all the components of this, because most of these components tend to overlap. But the key aspects in any of these components would be what we all discussed. Someone having cancer on the background gets higher points. Someone having had a history of PE or a thrombophilic state, or having a history of venous thromboembolism gets a maximum score. And all other age, heart failure, previous stroke, all these get additional points. So those are the general components in most of these scores. Okay, Mahesh, we can move on.
So after this one, sequence of events led to his hospitalization. First, it was like mid of December, trauma to the long bone and fracture, underwent major surgery, then worsening of oxygenation in the post-operative period after getting discharged, then presented to our hospital with shortness of breath with additional complaints.
So just then, Mahesh, what do you decipher from the third thing, worsening of oxygen in the post-operative period? What does that indicate? Is that having relevance to this particular case? Or?
Because he has a baseline oxygen requirement of 2 to 4 liter only, and post-operative period at home he has this rise in requirement of oxygenation. Okay. So relevance is there.
No, the post-op period, I thought it is in the immediately after surgery. So you are trying to say it is at home after surgery at home.
At home.
I don't know if the wording is post-operative in that sense. What do you say, Venkat?
Yes, I think it looks something like the post-operative decompensation with the possibility of maybe as a basal atelectasis, aspiration. All this will also be there.
Generally, post-op, Mahesh, for us implies that after surgery, someone has developed complication. Just a technical thing.
More predominantly related to the anesthesia-related complexities at the beginning. Okay.
Continue, Mahesh.
So on examination, first vitals, heart rate was means 124 with tachycardia, then respiratory rate 44, tachypnea, and then hypotension was there, means with 7 ml of noradrenaline, patient was maintained with 107/54, and baseline saturation means saturation at the time of presentation with 10 liters of oxygen is 89%, and local examination, patient was moderately built and nourished, no rise in temperature, and tenderness was noted in right hip region, and there are no bed sores like thing, because wanted to mention because this patient was bedridden.
So what does this indicate? Now the differential still remain the same, Mahesh. Now heart rate is 124, tachypnea, and is hypotensive also, and saturating at 89% with 10 liters. So he has severe hypoxemia also. So what do you make of this situation, Mahesh?
Here with this, I can assume that SOFA score I can apply here, sir. So with SOFA score, there will be a possibility of sepsis, I can feel.
So what are the components of SOFA score which are fitting here? You mean to say proper SOFA which needs all the values, or you mean to say quick SOFA?
Quick SOFA.
What are the things which fits into quick SOFA here?
Altered mental status, hypotension, and tachypnea.
You said patient has no altered mentation, or patient had altered
mentation? Yes, sir. He was conscious. So more than two factors in quick SOFA will have.
So blood pressure there, for the hypertension, is it fitting into the hypertensive state right now? Even though we see there is a drop in blood pressure, but it still remain to be more than 107 systolic. So you still don't fit into there. But anyway, it can be you have one of the component which you already said, infection like a community acquired pneumonia which remained there. That's what you mean to say.
And when you say PE, what is the commonest sort of a signs that you would see, Mahesh? I'm sure you would have read about what are the commonest signs that one would see.
On examination means
on the slide you're presenting, yes.
Tachycardia will be there, sir.
Okay.
All your panelists are typing tachycardia. So that's the commonest, because in fact, during my post-graduation days, the commonest teaching our bosses used to say is new onset tachycardia or AF is the commonest presentation of PE. So even it could be new onset AF or tachycardia. Tachycardia is the commonest one. So 70% is what is reported.
Okay. Next, what are the other things you find, Mahesh, other than tachycardia?
Signs.
Yes. After tachycardia, you had all of them. So you see tachypnea in them.
Yes.
Okay. You see hypoxia in them.
Yes.
So these are the initial signs which are commonly you encountered. These are
Exam,
non-specific. Most of them are non-specific, but they are the commonest presentation when you actually come across them.
I think tachycardia and tachypnea remains the commonest, Mahesh. I'm sure you would agree. Would have read this.
Okay.
So you can move, Mahesh.
So systemic examination means respiratory system. Room air saturation was 83 as per history, and tachypnea was there with respiratory rate of 44. Auscultation was showing bilateral air entry decreased both sides, and crepitations were heard till interscapular border. Right side bronchi were heard compared to the left side. And other systems, CV means cardiovascular system, central nervous system, and GA are normal.
So what is your take from these examinations, Dr. Mahesh?
So predominantly hypoxia.
Okay.
Then
Is crackles something common, Mahesh? Crackles you hear?
So you said bilateral decreased air entry. Why do you expect, and what are the possible causes for bilateral decreased air entry? Are you changing your diagnosis here?
bilateral air entry was there, sir, but it is decreased. And crepitations were
So what are the common
sides.
possibilities when you see a bilateral decreased air entry? Is it common with thromboembolism? What are the differentials when you speak about decreased bilateral air entry?
This patient, it is basal atelectasis can be the possibility. Sir. Aspiration is also the possibility.
So in
prolonged aspiration. Means most commonly it occurs only one side, but
and even Mahesh mentioned right side bronchi compared to left side. Is that something very common that you hear bronchi only on one side? I mean, as a clinician, we seldom see that, isn't it? Only one side bronchi. I would wish to hear from our panelists. Is one side bronchi something commonly you hear? What was in your mind when you mentioned that right side bronchi heard compared to left side? Was there something you're trying to tell us with that? Because you have examined the patient, you are presenting the case, so you should know more information as to what you're trying to tell us by saying right-sided bronchi, crackles, reduced air entry. That's what we want to know. I'm sure every listener here would know once you say something, we would want to know what you're trying to imply that patient has. Because you've gone through a lot of exams, MBBS, MD, everything. And this is what we expect. When you say something, we want to know what is in your mind, that you are telling us that there is right side bronchi. So basically in exam, Mahesh, especially in critical care, let me make it clear, we don't want to hear a lot of unnecessary things, which possibly may not have relevance to what the diagnosis you're trying to convey to us. Because we only want to hear all the relevant positive aspects. Because I'm sure we all, when we went to MBBS, we used to say a lot of negative history, no history of this, no history of that, this is not seen, that is not seen. But as we advance more so in critical care, we want you to grasp all the key positive signs and symptoms which take you towards establishing the diagnosis. I think so. Let us be more practical, Mahesh, so that even in exam, when you go for exams, you wouldn't want to hear certain things where we are not able to make sense out of it, Mahesh. Venkat, you agree with that?
Yes. So, Mahesh, what is your expectation? See, you said this is a CKD patient, there is a CAD. So, when you see a drop in bilateral air entry in a 72 years old guy, what will be your differential? See, don't go into the diagnosis because this case was given to you, you know the diagnosis. That's not the point. No examiner in exam will like to get into the conclusion. They wanted to see how the student is approaching a case. See, at this point of time, I don't know what is my diagnosis. I'm still into the clinical examination. So this case can go anywhere. Suppose this patient's the CTPA is clear and normal. So what could have been the other differentials in this case? And I want my student or any clinician in the intensive care to think in that way rather than they going only in one direction. So when you have a bilateral air entry, are you expecting a bilateral pleural effusion? Do you expect some mucus plugs, that to bilateral basal atelectasis because the patient is not breathing adequately and because post-surgery or any other things made him in that way? And what are the other common findings you see when you speak about a pulmonary embolism? Do you see this decreased air entry as a common phenomenon? As Dr. Rangappa sir was asking, whether it is related to Krebs and bronchi, are they common? How are the presentation? What will be the common presentation when you actually look for a pulmonary thromboembolism?
Mahesh, see, all your friends, all your colleagues who are here, 360 people, they're all typing it's pulmonary edema. I agree with them because she is a CKD, desaturation, tachypnea, having crackles, and even bronchi can be present when they go into florid pulmonary edema. So I agree with them. With this examination, you are hinting to us that possibly is in pulmonary edema. So I absolutely agree with a lot of panelists who are typing in the chat box that it is pulmonary edema because it fits into it. A lot of crackles, reduced air entry because of pleural effusion due to CKD, and bronchi can be present in flash pulmonary edema. So that's what it is at this point of time. So is that what you are trying to tell us, Mahesh?
Yes.
Okay. So, see, the other differentials which we are looking at is, we said there can be a community acquired pneumonia. So if you find an area of somewhere you are looking at a bronchial breath sounds with a crepitations, and that area there where there is a decreased air entry, and that can be again an area of your differentials in them. And the second question is, what are the common presentations or what are the common signs or examination findings in a pulmonary embolism? These are all differentials with your current finding. What are the common presentations, findings in a chest examination which will hint towards a embolism?
Means on examination.
Yes, on clinical examination of your respiratory system, what findings will make you more tilt towards a embolism?
Tachypnea, then hypoxia.
They are all done. Now we are talking about a respiratory system examination of your auscultatory finding, whatever you are talking about now. Tachypnea, tachycardia, hypoxemia are done. What will happen to your breath sounds? What should happen to your add-on sounds? Are they common in them, or what happens? See, what is the problem? Is it a problem with the lung initially to start with?
Problem is in right heart, it's right side of the heart, pulmonary embolism.
So it's an embolic phenomenon to the vascular bed. So most of the times, to start with, the parenchymal findings or the lung findings or auscultatory findings in a respiratory system examination may be absolutely normal. You may have a bilateral vesicular breath sounds without any added sounds in most of these patients. Still, you get a inflammatory phenomenon, pleurisy, pleuritic chest pain, inflammation, leading to some Krebs. Sometimes also bilateral wheezing can be a phenomenon in embolism with inflammation, but most of the times it can be also normal. So if I have a patient whose respiratory examination, except tachycardia, tachypnea, and hypoxemia, is absolutely normal. I have more inclination towards looking at a vascular beds than just a parenchyma. Dr. Pradeep Rangappa, do you agree with me when we actually look at a pulmonary embolism as a possibility?
Yeah, I can see most of the pulmonary embolisms, as we all agree, especially in a patient elderly who is having a lot of comorbids, you would possibly find mix of all these findings. But when you overtly put it as so many findings, so it may be hard. But for as all the panelists are, as all your colleagues are mentioning, the most evident thing that appears to me is that he's quite unwell because of a lot of crackles and CKD and other things. So it's very hard for me to say at this stage that PE is the overriding problem with the clinical sort of a examination findings you're mentioning, because crackles till the interscapular border is little uncommon in a PE, because PE many of the times it can be a silent just a few crackles. So it's little hard at this point of time, but anything is possible. So.
See, Dr. Mahesh, wheezing and crepitations can be a phenomenon, can be a possible in embolism with inflammation and all that. But see, when we look at this case, see, in like a theoretical textbook, you may not have only one disease in this patient, as rightly pointed out in Rangappa sir. See, in clinical context, when you see a bedside case with such an elderly gentleman with multiple comorbidities, you will have a 2 or 3 phenomena overlapping with each other. Yeah. Whether you see a shock, it can be just septic, you may have a cardiac component, you may have a hypovolemic component. In a trauma case, it's not just an hypovolemic, but you may also have a component of some kind of obstruction with a tension pneumothorax or something else. So in these patients also, you may have a suspicion of thromboembolism, but the same patient may also have a volume overload state, may also have an aspiration pneumonia add on to that, may also have a component of septicemia going on. So there can be 2 or 3 things overlapping. So when you explain a particular examination, like you say bilateral decreased air entry, you need to have an explanation for that when you actually appearing in exam and pointing out that. And when you say I have a crepitations here or intrascapular areas, then you need an explanation for that. And when you say I'm hearing a rhonchi or a wheezing in a particular area, you need to have some explanation for that. These are all possibilities. At the end, probably you will confirm them by further investigation. So we'll move on to the next slide.
Yeah, I think one of the listeners has mentioned murmur. Murmur in P is unlikely, but what is referenced is you can have a 4th heart sound and loud P2. So these two are possible, but murmurs are not the part of P. Just answering to one of the chat box questions. Okay, Mahesh, you can move on, Mahesh. What is that handwritten? The summary.
So on the day of presentation, after assessing, patient was with these issues, like he was in shock with noradrenaline requirement of 7 ml per hour, and then tachypnic requiring 10 to 15 liters of oxygenation. And then after that, we went to NIV with FiO2 of 70. Then the baseline investigation showed that hypoxia is there and raised ProBNP was there. The baseline investigation we have ordered were like hemoglobin was 9.6 with baseline creatinine was 3.47.
Okay, Ken.
Just then, the previous slide, you have written NIV and HFNO or something. I just missed that.
In the course of.
Okay. So, okay.
Then significant investigations included D-dimer was 10,000, and then ER venous Doppler screening was showing positive for DVT. Then ProBNP was 22,000. The RT-PCR was negative.
So what is the significance of these investigations, Mahesh?
D-dimer means D-dimer raised, sir, and then venous Doppler screening was showing positives for DVT. That supports pulmonary embolism, sir. Raised ProBNP can be again
But looking at this, as Venkat rightly said, Mahesh, all three possibilities prevail to me. You know, there can be a cardiac event, there can be a sepsis component, and there can be a DVT bar PT, isn't it? And TSH also is high. 29 is high.
Yes,
I don't know
yes.
what's your reference
So
range.
you have given the significant abnormal values in this, okay? And these all values, as for your information, are abnormal. So this patient there is no rule that if a patient had a thrombus or embolism, they will not have any other problems, or they will not concurrently will have comorbid. This patient already had a list of comorbidities. There can be an acute problems also. There can be multiple acute problems. So can you enumerate the possible problems in this patient? These are all lab findings.
For CU is showing pus cells of 50 to 60. So there could be chances of UTA. And then sputum was showing many GNBs, gram-negative bacteria. Can be possibility of pneumonia. Then D-dimer, inflammatory conditions were there. But then proBNP means cardiac mark as a cardiac marker. Trop I was negative, but proBNP was raised here, sir. Trop I forgot to mention here. So
was Trop also high, Mahesh?
No, sir, negatives.
No.
So just for the sake of the discussion, we will ignore the other components. You have said, as you said, there can be two infective sources. One can be urinary tract leading to urosepsis. There can be a possibilities of a aspirated pneumonia or a community acquired pneumonia. It is not just with a sputum culture, but there are many other things which need to correlate it, because you can have a lot of colonization also. Now coming back to the three components, you said D-dimer and anti-proBNP or a proBNP and also troponins. So what do you think these all three indicating towards? So you said D-dimer and a venous Doppler is indicating toward a possibility of a thromboembolism with hypoxia. Pro-BNP and a troponin, which you have not mentioned, which are positive, you are saying, what do they indicate?
See, at this stage, Mahesh, one minute. At this stage, Mahesh, for all the listeners, I wish to say one thing. So this is a typical ICU situation where I want to emphasize that every ICU patient will be like this. So very good, Mahesh. I'm happy that you have presented a case which is a garden variety VC. We don't see textbook description of PE. We see typically in ICU cases which have complex interplay of multiple issues, like what exactly Mahesh is presenting. For all the listeners, the key thing about intensivist, the art of intensivist is to identify what is the overriding problem for this patient. I think that is the crux of this whole case, Mahesh. So don't get overwhelmed. This is a typical garden variety case we see every day in our ICU. Our whole business in ICU and for all the future intensivists is to see what is going to kill this patient. That is what we are here to decide. If it is sepsis, obviously we have to go on the path of sepsis, trying to put in all our armamentarium to address sepsis issues. Okay. If it is a cardiac issue, if it is a MI, then you should be possibly going to cath lab if needs be, or any other support or interventions that needs to be done, if that's what we believe is going to kill this patient. And the third thing, what you are pointing out time and again from the beginning of the case, is P. If P is going to kill this patient, then we have to address this. So I think that is where our whole science is, Mahesh. I think that's what we are all constantly, me, Venkat, all of us are here deliberating. What is going to trouble him? What is the overriding issue in him? So that's what I want you to tell me from your investigations you have done, from the examination, from the history. What is it that you think in this particular case is going to trouble him?
And need immediate attention or prioritizing your attention.
With these investigations, the DVT means venous Doppler was showing positive for DVT, and then D-dimer was showing more than 10,000, and proBNP is showing that cardiac marker as a stress strain marker of cardiac. We can say that.
So your priority will be to evaluate for an embolism. Okay, we'll come to. There is a high TSH. The cutoff will be much lower than this, as rightly pointed out before also by Rangappa sir. What do you think? Why the TSH is so high? Is this been a known hypothyroid patient?
Not a known hypothyroidism.
We even don't see such a high TSH level in even sick thyroid states. It's too high for even leveling it as a sick thyroid state. So that probably
I have
again need
one.
a, yeah, go ahead, Mahesh.
Mahesh, that's a very relevant point. Would that TSH 29.7 with an obtundation, you did say is incoherent, would that worry you in this patient?
Yes,
Your colleagues already mentioned myxedema
yes, sir.
coma.
Mixed.
Why does it worry? Why does myxedema, if at all we are dealing with the myxedema coma in this, because he has swelling of the limbs, you said, with edema, and he is obtunded and TSH 29.7 with the recent COVID and with possible underlying sepsis. What is the clinical ramifications if it is myxedema coma for this gentleman?
One thing, means tachycardia will not be there, sir. And then patient is conscious, and pretubular edema was not there. This edema was disproportionate edema both sides, and will go against mixed edema coma.
Okay, good. You have a valid point, but if you are labeling as myxedema coma, the mortality is going to be very high. Okay. So it's going to be nearly 100% mortality most of the time, especially when they have so many problems. So just to keep that in mind, if you are entertaining myxedema coma, mortality is going to be very high for this patient. And I agree with you. He has tachycardia and he has disproportionate pulmonary edema. Now we have a PVT sitting there, so possibly that goes little on the back foot at this point of time.
But at this point of time, with this information, I will keep all these things under my mind, or I'll keep all these things in the mind. All these differentials will continue till I get a further information. So my myxedema coma, my urosepsis, my possibilities of a community acquired or aspiration pneumonia all remain there, including a cardiac event. I'm not fully now confirming a possibility of just a PTE. This can be an ACS. This can lead to a heart failure because I have not investigated further. Okay, next.
So the further investigations was revealing, sir. So 2D echo was showing, 2D echocardiogram was done, and it was showing ejection fraction of 62 with fair LV functions. And adding to this, TROPI was negative, so we can eliminate cardiac.
See, Mahesh, at your level, you are a DNB final year or IFCCM. Even in IFCCM or any exams, we would expect you to show echocardiographically yourself the windows and what you will be looking for. So this report done by a echo technician is something which may not be well appreciated in our exams, because at your level, we would expect you to show us the windows and maybe an image of the window that is going to give you some clue what the underlying diagnosis is.
There is another information. We request all the students not to put any kind of these kind of reports, not hiding the patient's privacy. So this has to be, as pointed out, the echo image and your view if there is a view. We appreciate that you brought an original live case, which we meant is a bedside case, because most of you get a bedside case where you may sometimes don't know the diagnosis and you need to go through the whole case. It can have a mix of multiple things, so that we appreciate, but don't try to put any kind of these images of or photographs of the reports. You can mention them, or you can actually get the image of your echocardiography. So go to the next slide.
So Mahesh, you tell me in echo. So you got a very valuable echo machine. A lot of your panelists are the colleagues. Sorry. So all the listeners, you type in what is it that you look in echo very quickly. In 5 minutes, what are the key things that you would look for in echo? Because that would be a clincher in this case. So Mahesh, you also keep telling. I'm seeing the chat box.
Change the slide, Mahesh. Then you just tell us that what are the key things you wanted to look in echo.
In this case, RAR means RARV was dilated and right ventricular outflow tract, then right ventricle by left ventricle diameter, then TAPC, tricuspid annular systolic excursion, then mitral means tricuspid valve, tricuspid annulus velocity, then the ratio of RV by LV, then interventricular septal thickening and D shape, and then
Okay. Okay. What is there in your mind? What are you going to actually? Why are you looking at all this?
They means in case, because this case has DVT and raised D dimer, there I'm thinking of about pulmonary embolism.
Okay. So let me stop,
So
Mahesh. I have seen lot of typos here. Thank you so much, all my good friends who have typed. Everyone is very fixated to RV, as I see. I think 80-90%, some repeatedly McConnell's. Tell me how many of you have seen honestly McConnell's. In ICU, as we say, look at this case in a very comprehensive way. When you're doing an echo, this patient, we have been time and again mentioning he has sepsis on the background. Possibly there could be a cardiac event and there could possibly be a PE. So we have to look at all these aspects because we want to rule out whether there is a LV dysfunction, whether there is a diastolic heart failure, whether there is a LV failure. So it only takes possibly 5 to 10 minutes to get information about your LV or whether diastolic function or whether there's LV failure and RV size and RV dilatation and RV strain. So these are the only things that but most of the listeners here are putting only pertinent to RV. It is important that you do a comprehensive assessment. It only takes possibly 10 minutes for you to take all the two to three views to get all this information. Because we are in the ruling out business, isn't it? We have to rule out it's not LV function, it's not overall, or it is not stress cardiomyopathy, or it is not biventricular dysfunction, and it is not diastolic heart failure, or it is not pericardial effusion or tamponade. So all these things we need to see to fixate our attention. It is predominantly RV effect, isn't it? So we wouldn't only keep looking at the RV indices. So that's what I would be, sort of emphasizing to all my listeners that when you do an echo, you need to get a 360-degree sort of a view about the whole function of the heart. Venkat, you agree with that?
Yes, sir. Yes, I think what is the importance of echocardiography, Dr. Maya? Suppose I have a patient who is came to that emergency room, and obviously it takes a longer time your D dimer to come back, and he's been dyspneic. You had a differentials of 3-4 things, myocardium, or this is a pulmonary edema, or this can be a pneumonia, and this can be a PT. What is the role of echocardiography in them? I know D dimers take their own time, their own sweet time.
Can change the plan of management also, sir. Like if a frank RV thrombus is there, visible by an expertise person, you can thrombolize directly.
So in which patient category? Anyway, we'll come to that. In a patient in which patient category you will directly do those attempts?
A patient means cardiac arrest was developed or any visible RV thrombus with hemodynamic obstruction, hemodynamic instability developed, then
so
means echocardiography can be taken as a decisive maker.
So high risk cases, high probability cases with echocardiographic finding of RA-RV dilated or any typical mechanism signs would be enough to actually treat these patients in the same emergency room. You may not able to get all those findings which you see, and as we discussed in this case, there may be many comorbidities. If the risk of bleeding is less, there are no absolute contraindication. Probably echocardiography is the only bedside quickest test which will be available. A D dimer may be turned around for 2-3 hours. So that is the only. And you mentioned rightly about a CPR in this case, is a cardiac arrest, which is also quite possible. Massive thromboembolism or a saddle thrombus can be one of the commonest cause which can cause a cardiorespiratory crash. So in those situations, sometimes you may not even able to get any echocardiographic window. So what will you get? There is a patient is a pulseless electrical activity in a cardiac arrest state. What do? You may not even have any echocardiographic finding that standstill heart. In them with a high probability, with a low risk of bleeding, those are the patients which you may need to treat them with possibly a thromboembolic risk and treat them with a thrombolytic agent. So these are the important components in this situation. If I have a patient where I can get some echo window and a DVT with a hemodynamic instability is one. Otherwise, the patient is hemodynamically stable, there is a flow for that. So the echocardiography has that important role in your bedside, either in emergency or in ICU. And
Mahesh,
as
what's
rightly
the
pointed out,
yeah?
we need to exclude because this case still now we still are struggling in and around multiple possibilities. See, RA-RV dilatation can be common in many other possible conditions. If a patient is a known COPD, a smoker, a OSA patient, there we see them, most of them will have a RA-RV dilatation with a moderate to severe PH in them. So mistaking them because of a patient is a hypoxemia and also have RA-RV dilatation with a PAH can be a catastrophic misleading. So you need to keep a watch whether this patient has any other things, like it has a severe LV dysfunction with a poor ejection fraction, bilateral pulmonary edema with an effusion. So all these need to be kept in mind when you are doing an echo, just not a only RA-RV dilatation with a PAH. You should go to a conclusive evidence.
And what's the echo probability of showing your PE signs as referenced in literature, Mahesh? The typical features all my esteemed listeners are mentioning. How often that you would find echo findings? In 100% of PE or 50%, 40%? Panelists? 40, 30, 50. Okay, I think most of them are about 40 to 50%. That's all you get. So it's not like echo gives you all information about PE. So echo is to basically rule out all others. And even sometimes echo can be good even in picking up saddle thrombus. In parasternal short axis view, you can look into the pulmonary artery and pick up pulmonary embolus sitting in the saddle thrombus in the main pulmonary arteries, because you can see left PA and right PA.
So sometimes we may able to see a thrombus in transit in right ventricle or in the saddle position. But
have you seen any of the videos, Mahesh? I can show you one video of thrombus sitting in the left ventricle.
Yes.
And as you rightly pointed out here, there is an indirect way of putting evidence by actually doing a compression test, which will also show you some deep vein thrombosis in your lower limb. So that can also be indirect corroborative during these situations where you don't have a conclusive evidence, but you have a high risk patient with a hemodynamic instability. The risk of death in these patients will be high, and you have a low risk of bleeding. So these patients may go to treatment. So there both these tests will come into play in a probably priority way. Next slide, Mahesh.
For all the listeners, can you please let me know anything else you would look in echo? I told you look at RV, LV, pericardial effusion, and diastolic function, filling pressures, everything. Anything else listeners want to look into this? You can continue, Mahesh. Let me hear. Mahesh, you can tell us anything else you want to look in echo? Yes, very good. I got answer. IVC is very important. People have written IVC is very important because you are already having an hemodynamically unstable patient, and you may have to resuscitate this patient. So IVC does become important. PA pressures, of course, some people have mentioned, but it will take time. So IVC also is something I would look at. So there are key components which you have to look in 10 minutes. So IVC is always one of them when I do echo. Okay, Mahesh, continue.
So after rise in D-dimer and the rise in pro-BNP, we went for CTPA, and that was showing again thrombus, means thrombus in left side main pulmonary.
So now you have read everything about PE, Mahesh, for the benefit of all our listeners. Can you tell me how you do the CT sort of a grading of the PE? With regards to, because if you look at the CT, they would have written it is sitting in A2, A3, A4. So have you read about it? How do the radiologists look into the segmental? They'll say segmental PE, subsegmentals PE, and they will write regions A3, A2, A6, A7. So have you got any idea? Have you looked into this? What about all my esteemed listeners? Has anyone looked into?
Main pulmonary artery, then lobe, then segmental, subsegmental, then lobar branches.
Okay, so there is a very nice illustrative way how the radiologists look into segments. I'll show you the pictures if you have time at the end. It's all there on the, you can easily source all those, but I can show you. Okay, Mahesh.
How do you actually classify, Mahesh? How do you classify a thromboembolism?
Based on the risk, means massive and submassive, high risk, intermediate risk, and then.
So how do you classify them? When you call massive, submassive, and low risk?
Massive, when there is a right heart failure, right heart dysfunction features are there, then we can call it as massive. And submassive, when there is no shock or no right heart failure, right heart dysfunction symptoms are not there. Then high risk, as per, means there are 4 features to classify it as high risk.
Mahesh, don't get confused. When we say massive, when we say whether it is sometimes a saddle thrombus, but it may not be massive. They say when you have a hemodynamic instabilities or a compromise with a thrombus, sometimes it can be saddle thrombus, some can be even a thrombus on the main trunks can cause you a massive phenomenon like hemodynamic instability. Submassive may be with right heart strain, and low risk without strain. So these are that. And what is the acute, subacute, and chronic? So acute, which happens in acute in minutes to hours. So it is happens when it is in days to weeks, we say subacute, and chronic is when it overs a period of weeks. So that's how actually we classify them. We need to actually know all this because there can be a way to. So now we have come to some conclusive evidence that we are into a thromboembolism. So why do you think the thromboembolism do happens? What is the pathophysiology linked to it, which is again a common discussion which happens in the exam?
Someone mentioned in the chat, pulmonary artery pressure increases, Mahesh. So what does that imply? Pulmonary artery pressure goes up because it has a lot of pathophysiological bearing as to what it will indicate to you.
So when there is when RV outflow tract is increasing, means trying to push the blood against obstruction or raised vascular resistance in the pulmonary bed, the pulmonary artery pressures will rise up.
Okay. Is there any referencing for that, what you are mentioning? So usually there is a mention that when 40% occlusion of your pulmonary vessel happens,
35 to 40. Yes.
Yeah, that is when your pulmonary artery pressure. So it basically indicates, yeah, it basically indicates it's a very clinically significant pulmonary thromboembolism.
Okay, now how do you evaluate? We were asking about the risk of this thromboembolism pathophysiology, Mahesh.
Disturbance in Wickrow triad is the basic pathophysiology behind the.
What are the components of Wickrow triad?
First, stasis, then hypercoagulability and endothelial vessel injuries are the components.
How do we actually evaluate for a hyperthrombotic states or what are the, as you said, there are 3 components. So one of the component is vascular injury and stasis. Anyway, those has been discussed. So how you actually evaluate for a thrombotic or a hypercoagulable state? Or what are the causes?
Causes includes acquired and genetic causes. So acquired immobility, then cancer, immobility, cancer, male sex, pills, parity, pregnancy, paraphilias, paraproteinemias, all those things. And then acquired means inherent risk factors, again, either increase in procoagulant factors or decrease in anticoagulant factors or fibrin modulation like things. Increase in procoagulant factors includes like factor V lead-in, then prothrombin mutation, G20210 mutation, then dysfibrinogenemia, then
Okay, good,
other
good, good, Mahesh. We can,
Okay.
I think we can move forward.
Move forward.
So the first baseline ABG of this patient at 5 liters with 40% FiO2 was showing a PaO2 of 75, sir. Baseline.
So Mahesh, just for the constraint of time, what is the findings you expect? What are the findings you expect in a patient with a massive thromboembolism like this? Or what are the common findings and what are the findings you expect from a massive thromboembolism in a ABG?
So what will be the AA gradient for this, Mahesh?
Normally, for this patient, AA gradient was more than 70.
Yeah. So at your level, we would expect to calculate AA gradient.
So what are the findings you expect in an ABG? You already
Rise in
mentioned
AA
about
gradient.
hypoxemia. Okay, that is one. What happens to the AA gradient? How it will differentiate between other possible causes?
Rise in AA gradient will be there, sir.
Right. And what are the other possibilities? Other problems in ABG?
Hypercapnia can be possible.
Hypercapnia is a common?
No.
What is the commonest ABG findings in a patient with thromboembolism?
Hypoxemia. Hypoxemia.
After that, hypoxemia is A gradient rise, hypoxemia is done. Next.
So carbon dioxide is a,
what happens to the carbon dioxide? Is where hypercapnia is common, hypocapnia is common? Yes.
Because of tachypnea, hypocapnia will be there.
Yeah, the most common presentations in ABZs will be hypocapnia. But is there any possibility that this patient can also have a hypercapnia? There is no exchange at all. When you actually have a complete occlusion with a massive thrombus with a cardiorespiratory crash with hemodynamic instabilities and probably needing a CPR.
In the later stages can have.
It is only in those cases where you see a hypercapnia, but the rest of the times it is hypocapnia. If a patient is tachypenic with hemodynamic stability and patient has a hypercapnia, I will probably rethink about my diagnosis in them in an alternative way. And A gradient in them is an anticipated way. So in this patient, you have started with ABZ, you have given some clinical history, clinical signs. What are the other investigations you do in an emergency level in these patients? Patient is an ER. You have taken history, examination, and ABZ. What other investigation much before your 2D echo or a CTPA you can do in them, and what will be the other findings?
ECG and 4-point means DVT 4-point assessment.
Before that, this patient is an hypoxemia patient. What other things test we do in the emergency room in the bedside? What radiological investigation you do at the bedside in these patients?
Chest X-ray.
Yeah, so chest X-ray and ECG. What are the expected findings in a chest X-ray and ECG in these patients?
Most of the times, chest X-ray will be non-specific and will have no findings.
So maybe chest X-ray will be normal in them. So there are few signs with a wedge-shaped infarct which can be there, but that's not very common. It's very rarely found. So chest X-ray, if I am normal, so my suspicion to a thromboembolism will go high. If I rule out other possible causes, it's more like, as Rangappa sir was repeatedly saying, it is to rule out other possibilities. You said it can be a community acquired pneumonia, it can be a pulmonary edema, it can be a bilateral effusion in the initial. So to rule out that, you probably will need a chest X-ray, and chest X-ray being normal, with your clinical examination finding being normal, can give you rise to a suspicion for more of a vascular event than a parenchymal or a ventilator event. What will be the ECG finding? You spoke about ECG.
Tachycardia, raised heart rate will be there. There will be
Tachycardia, sinus
typical, very
tachycardia.
non-specific findings like S1 Q3 T3 wave pattern, that is non-specific. Means will not be there in much cases.
So
Then
even
bundle branch block.
Fashionably, we talk about S1 Q3 T3, but the percentage of cases with which we see S1 Q3 T3 is extremely low. So it's a very. What are the other ECG findings which you see?
Right bundle branch block pattern will be there most of the times.
Anything else?
No, but RVH strain.
Right axis deviation can be there, sir, in patients chronic.
Okay, is there any arrhythmias which are possible with them?
Atrial fibrillation can
So
be
atrial
possible.
fibrillation palpitation can be a symptoms in them. RBBB can be found in them. Sinus tachycardia can be found in them. And this again, stretching your pulmonary trunk sometimes also lead to a hoarseness of voice. And you mentioned many symptoms. A rare component in this also is many of these patients can have a syncopal or near syncope kind of phenomenon in them.
Yes.
So that is again kind of presentation which can be rarely seen, not common, but they are all possible. So these are all ECG non-specific findings. And when you see S1Q3, Q3, probably your diagnosis towards the possibility of a pulmonary thromboembolism. Does it actually adds any other prognostic value?
ECG findings.
Yes.
Will actually right heart strain will be there in ECG, sir. So that can be prognostic.
Okay.
But
Anything from you, sir, Pradeep sir? Or?
I think that should be good enough, Venkat. So predominantly non-specific, but we see quite often S1 Q3 T3, although it is said it is not very commonly seen. We have seen many a times it does occur. So one of the key questions we ask is, if you have a R wave in V1, what are the causes of R in V1, Mahesh? So that's a very common question we ask. Still, some of my trainees struggle to answer that because this is a very basic question we expect. So what are the causes, Mahesh? Because we show you ECG in exams typically, and you will see an R wave in this in V1. So we would ask, what are the causes of R in V1? All the listeners, you can, yeah, I see one of them has answered 3 causes. I want 5 causes. If anyone can put in one post 5 causes. You're all putting one cause. If you're typing, type all the 5 together. So I'll see who is typing. One is RBBB, you said. PE is one. PE and RBBB. Then
pulmonary right axis deviation with pulmonary hypertension.
All that come under one category. Any other causes? RBH, someone has mentioned. This is something we expect as a basic question, Mahesh, because we are looking at differentials. Always in intensive care, we want you to see what are the other possibilities that you are ruling out, isn't it? Time and again, we look at it. So it's important you read about it. So it's WPW syndrome, very important. True posterior wall MI is one. RVH is one. RBBB, PE, and it can be a normal variant. So, and muscle dystrophies. So all these are causes. Okay, Mahesh. Anything else in the slides? Then we can go to treatment aspect. Isn't it, Venkat?
Yes, sir. So
Okay.
how do you go back to the, how do you treat them?
I think you can stop sharing, no? If there are no slides,
Yeah.
then at least.
Yeah, we can come into the, yeah. Go ahead, sir. Ask about the treatment so that from here we can.
So Mahesh, now this patient, you have deliberated a lot. You have made a diagnosis of PE possibly, and you have ruled out, there may be a little infective component because you had a lot of cultures and all other things. But I saw the lactates had not gone up, so which goes possibly against sepsis. Mixed edema coma is possibly not high on the list. Cardiac event we have ruled out because we have done echo. And you said troponin can be high in PE and even your BNP can be high in PE. So now we have diagnosed a PE, which is an unstable, hemodynamically unstable PE. So how do you go about managing this patient, Mahesh?
in hemodynamically unstable patient, first we will prefer to go on anticoagulation, means thrombolysis with fibrinolytic agents plus anticoagulations.
So is there evidence for thrombolysis in hemodynamically stable patients in PE?
Yes.
So what
In
is the evidence?
hemodynamically intermediate and low risk embolisms also there is a
Dr. Dharanindra said no. So any other esteemed listeners want to disagree with Dr. Dharanindra? In hemodynamically stable, is there any good trial that has come out? Do not agree, someone has written. Moped trial. Is that in hemodynamically stable?
Yes, sir. In intermediate and low risk pulmonary embolisms, they have tried with anticoagulation plus low dose thrombolysis also.
I think someone mentioned Plithos trial. Plithos, who is that? Someone
Plithos trial.
Shankar Duraisamy mentioned Plithos trial. That was in hemodynamically stable. Also, they looked into it. Thrombolysis in hemodynamically stable. So that came in 2014. Plithos trial. It was by the French group. They showed thrombolysis in hemodynamic stable patients had a good benefit, reduced hemodynamic collapse in that trial. But why we are not following that? Because it showed increased risk of bleeding.
Bleedings.
So Plithos trial is important. It came in NEJM. It's a French trial. Good, Doraisamy, good. So yeah, so
go ahead.
So you would thrombolyze this patient, Mahesh?
Actually, for this patient, recent history of major surgery was there. So I will not go for thrombolysis.
Okay.
That's why you have started.
How long back was the surgery? How long back was the surgery?
14 days back.
Okay.
Major surgery in the past 1 month.
So you said the hemodynamically unstable and stable. How do you define Mahesh, hemodynamically unstable?
Hemodynamically unstable, either cardiac arrest or obstructive shock, or else right heart dysfunction.
Obstructive shock?
With predominant right heart dysfunction, right ventricular dysfunction. Hypotension.
Hypotension of what? For what is the period? And with volume resuscitation, it doesn't subside. Is there any criteria which we say this is a hemodynamically unstable? So we have a systolic pressure less than 90 for 15 minutes of time with volume resuscitation, it persists. Then we probably believe the patient is going into hemodynamic instability with organ hypoperfusion, or a patient who is in a cardiac arrest situation. So in these patients, before a thrombolysis, will you actually reconfirm a possibility by some way which we discussed, that probably with an echocardiography which can be done? Do I need to confirm these cases by a, how do you actually confirm? As you confirmed in this case, will you wait for a confirmation in a patient with a cardiac arrest and a patient with some kind of these situations?
For hemodynamic instability, sir?
Yes, hemodynamic unstable patients and cardiac arrest patient, will you go for a confirmation and then thrombolyze, or what will your approach?
No, sir. Here echocardiography will be the investigation of choice. If we see that any thrombus in right heart, then we can directly thrombolyze, because it is a life-saving.
You don't see a thrombus and a patient has a high risk group with right heart strain. Will you have an option of thrombolysis in them?
Yes. If the refractory cardiac arrest is there,
okay.
Not
this patient, you said as a major surgery, we believe this patient had a 2 weeks back, that to hip replacement and probably a compressible area. So this is again a weighing risk between a chances of bleeding to a life-saving procedure. If a patient goes in hemodynamically unstable or a cardiac arrest, then the risk, the chance of options of thrombolysis will still remain open. But I'm just asking you, if these patients goes into a shock state and you can't thrombolyze because of some recent surgery or a stage where you have a risk of bleeding, what can be the other options in this patient?
If the patient is developed cardiac arrest, then we can go for extracorporeal CPR, and then extracorporeal.
Before that, if the patient is not in cardiac arrest, hemodynamically unstable, but he has a contraindication for thrombolysis.
I think you have
thrombolysis.
a lot of answers coming on the chat box, Mahesh.
Catheter-directed thrombolysis.
So catheter-direct thrombolysis, thrombectomy, and all. Suppose the patient has a cardiac arrest and you are doing a CPR. What are the options you have? You are thrombolized, the patient is not recovered, or what are the other options you can explore?
Surgical thrombectomy, catheter-directed thrombolysis, then IVC filters.
So the open chest embolectomy and bypass can be another. You said eCPR can be another option which can be also dealt in these patients. Suppose these patients are hemodynamically stable and had a evidence of thromboembolism. As there has been discussion, which patients may still be a candidate or a optional for you to thrombolize? What are the risk factors or additional points which will add you? Hemodynamically stable, but maybe a candidate in which categories? You said intermediate risk, submassive. In what are the other indicators which may give you a clue?
Hypotension, then SPC more than class 3, then cardiac biomarkers rise, then NT-proBNP values, and these values can.
Okay.
So Mahesh, we will consider this patient was reasonably stable and the thrombolysis was contraindicated. So what is the choice of anticoagulation? Even all the listeners, please type what is the choice of anticoagulation in this particular patient.
Patient's baseline creatinine was 3.47.
Okay.
So we'll go for unfractionated heparin only as a therapeutic anticoagulation of choice.
So what if you have a choice in unfractionated heparin, what would it be for this particular patient?
Fractionated heparin with therapeutic dose.
Okay, so you wouldn't use low molecular weight heparin in this?
Yes, sir. Based on creatinine clearance, we can use Cordially. If the creatinine clearance is 30 to 50, we can use.
Okay. So which one would you use? I'm just seeing the chats. So a lot of people are telling unfractionated heparin. So, but what do you do in your practice? I see dalteparin.
Unfractionated heparin only.
Okay. After that, you will change over to low molecular, or you will?
Practically, we have changed in these patients.
Sorry.
But in this patient, we have changed to Clexane later. Means low molecular weight.
What is Clexane?
Low molecular weight.
What? So it's very important, Mahesh. In exam, we don't wish to hear all the trade names, because I have had candidates not knowing what the molecule name is in certain cases, especially dalteparin. They say fragmin, but they wouldn't know what the component is. So it's very important you talk for the molecule name, because the reason I'm asking this is dalteparin is fairly safe because he's a CKD patient. Enoxaparin has an issue, but for dalteparin there is no dose adjustment in CKD patients. So one could consider,
and tinjaparin doesn't have any dose adjustment.
Yeah, so we could consider dalteparin for this patient because many of them in the chat box did mention. So what would be the dose of dalteparin, anticoagulation dose?
100 international units per kg, 12th hourly, or 200 international units per kg, 24th hours.
What is the role of oral anticoagulants later, and what will be the duration?
Later, once the patient gets stabilized, and then once there can be considered as oral anticoagulants.
What oral anticoagulation you will give in this patient?
A 72-year-old male, sir. So I'll go for either direct thrombin inhibitors or factor Xa inhibitors.
Are they been used or indicated, and we have enough studies to use them in a CKD patients with a creatinine clearance less than 30?
Yes.
We have evidence to use them, and what are the molecules we can use, and what is the duration we need to use.
Till 3 months we can use.
So is this a provoked DVT or unprovoked DVT?
Provoked DVTs.
So what is the difference between a provoked and unprovoked?
Provoked DVT is like acquired risk factor associated DVT, and unprovoked is the one which comes like inherited.
What is the importance of this?
So one provoked one is reversible, means after stabilization we can stop the
I'm asking
anticoagulation.
about, is it has any relation to the duration of an anticoagulation?
Yes, sir. In unprovoked, longer duration is needed, and provoked.
What is the longer duration? What do you mean by longer duration?
More than 6 months. More than 3 to 6 months is longer duration.
Unprovoked, it is more than 6 months. In provoked, it is less than 6 months. Is that what you are trying to say?
Yes.
So then if a patient is unprovoked with a risk factor of thrombophilic factor or a thrombotic state, after 6 months, you will discontinue this. So what are the indications of lifelong anticoagulation?
Inherited risk factors like conditions like
somebody has a thromboembolism with a malignancy. Somebody had a thromboembolism with a ANCA profile or ANA being positive, or a antiphospholipid anti being positive. Unprovoked DVT, but you on evaluation you found to have some risk factor. Sometimes you may not also find a definite answer in an unprovoked state. So you will discontinue them in a 3 months or a 6 months time. What will be?
discontinuous lifelong
Sir, your conclusive comments, and then I will like to listen from you that last slides, few slides which you want.
Yeah. No, I think well done, Mahesh. So I really was looking into all the chat sections, so it has been extremely interesting to watch all the chats. So Venkat, I have to congratulate you because every listener here seems to have been prepared for this case. And I could see that everyone is enthusiastic in answering a lot of these questions. So Mahesh, the crux of the whole case presentation is, don't get fixated. In ICU, we try to see how broad you think and converge to the priority or the acute issue that we wish to address. That is the crux of it. So we wish to go broad-based always, and then converge to the acute event or prioritize the overriding issue. We call it as an overriding issue amongst a lot of things, because this is a very good case that you have illustrated where a lot of things are happening. And here then we finally culminate to the diagnosis which is possibly causing more harm, at the same time addressing all the other issues also on the background. So that would be the way typically ICU works, because you don't get a garden variety medicine case where we ask you to examine and you see only pulmonary embolism and there's nothing else, or you see heart failure and there's nothing else. So there is always a complex interplay of some infection, some cardiac component, and some neurological component, and some underlying endocrine issues or some metabolic issues. So this is how typical ICU patient is. So it is always good for us, because the intellect we need is to decipher each of these, try to prioritize what is going to cause imminent harm to that patient at that point of time and address that first. At the same time, safeguarding the other sort of issues and trying to maintain some sort of a symphony between the other issues in the background. That would be the take home for this, but knowledge wise, I'm sure you would have read everything.
Sir, I would like to see your few slides which you wanted.
I'll just show some pictures, because I think before people leave, I think I see people leaving already. I'll just show that CT classification of that, because I have all these slides anyway. I would have done this for various teaching programs. So I'll just show you. So this is pathophysiologically, I think this is just I put in an illustrative way for people. So bilateral thromboembolism is very common. 10% of them have infarcts. So this is a VP mismatch, which typically happens in pulmonary embolism, where you have this thrombus sitting in the pulmonary artery side, and pulmonary artery pressure goes up when there's 30 to 50% of the occlusion, and this causes pulmonary venous resistance, which increases. And that actually you will have biventricular issues in pulmonary embolism. You have increased afterload. This is in the echocardiograph. This is how the heart looks. So you have an RV and you have a LV here. So there is increased afterload and there is a right heart failure, right heart dilatation, and then there is a TR jet that happens. And this leads to shifting of this septum into the LV, which causes reduce in the left filling pressure, and then cardiac output comes down. Because cardiac output, when it comes down, it is the later presentation of the PE, where you have a right heart which has gone into strain, pushing the septum to the left, and you have RBBB. So basically, this is the McConnell's one, where you'll see a predominant apex of the heart, and you have a straightening of this or the D component of the interventricular septum. And then you have a large RV with the underfilled LV. So I just want to show this video of the parasternal short axis, where you are seeing the pulmonary artery. See, that's the right pulmonary artery. I'll just show you the thrombus, how it looks. Just carefully watch, you'll see a bobby sort of a thing. This is the pulmonary artery, right pulmonary artery. Carefully keep watching that. You will see a thrombus floating there. You see that? There's a thrombus floating. Okay, so that's the video. So this is the symptoms, I think, which Mahesh very well presented. So these are the references for some of these symptoms. And signs and symptoms, as you see, there are a lot of studies. I won't take you through details. And these are all the BNP levels. 60 to 62% have high BNP. This is the S1Q3 T3, which we all talk about. And so here you see V1 does not have an R wave. So always differentials of R wave are asked. So this is some algorithms. I'll just, so these are all D dimers, which I'm sure. So some of the pictures of PE, which I wanted to show you. So this is how, these are the typical pictures we show in exams. So you see there is a proper left main PA, you see a big thrombus sitting there. So these are the distribution CT grading. So this is how we look at it, radiology. I'll show you the simple slide which you can remember. So basically your CT classification is dependent on the branching of the pulmonary artery into different segments of the lung. So that is how the CT representation of the PE as to which segment it is sitting. The easiest way to remember, which I follow, is this one. This is difficult. This is the easiest one. So where they would mention A1, A2, A3, and A4, A5. So this is all based on the segments and the lobes and that are involved. It is present up to A10. Okay, so all this is found on the web. You can look into it. That's why you would see in the CT they would have written PA sitting in the A4 segment of the lung, A10, A6. So they would mention. So that this is what they mean. It is reference to the branching of the pulmonary artery into each segment of the lung and each lobe. So these are the different scorings and which you all mentioned. So these are all the online calculators. So, and as you see, all these calculators have either cancer or the thrombophilia on the background. Okay, so you see here, CA, past VTE, they get the highest score. That's what I was mentioning. Cancer, past VE, thrombophilic conditions, they get the highest score. In all the scores, they get the highest. And all this age, heart failure, all those get lesser ones. So this is the primordial risk factor which intensivists should remember is age more than 40 and no mobility for more than 3 days with one of the thrombotic risk factors constitute the risk for PE. And all ICU patients, sick ICU patients considered high risk for venous thromboembolism. So this is all. So thrombolysis, this is the PITOS trial, which came from Germany, German group, 2014 in NEGM. Thrombolysis in hemodynamically stable. It had benefit in reducing hemodynamic collapse, but no difference in death. Okay, and increased bleeding risk was there. And this was a study for catheter-mediated thrombolysis. Survival rate was 87%. IVC filter for all intensivists, PREPIC study was there, which showed reduced risk of recurrent PE. This was by the French group. And the prognosis was the PRECID trial from the Switzerland. So this is the PRECID trial. So just some of the slides just to add to whatever knowledge that we gained today for all the listeners.
So any questions? I think we had actually a very fruitful 2 hours of discussion. Any questions anybody wants to ask? I think Dr. Rangappa tried to answer all the questions, whichever on the chat box, but anyone, if you want to unmute and
fluid management, someone is asked. That's very interesting. That's why we look at IVC. If you look at any literature for PE, if IVC is dilated, because RV is a diabolical situation, because you overload, it does not work. and if it's underfilled, RV does not work. So it has to be euvolemic. So you have to look into the LV component. You have to look at how severe is the RV failure. You have to look at the IVC. And if there is some sort of a IVC responsiveness in some way, gentle allocards, maybe very small mini allocards could be considered. Otherwise, fluid restriction is the way in someone who is hemodynamically very unstable. But echo would guide you to very gentle allocards. But predominantly, inotropes is what you may need. Now, at vasopressors and inotrope initially. But definitive management is the way to go with thrombolysis or establishing the circulation would be the way.
So somebody asking Novak's role, sir.
See, NOACs, so honestly for PE, there is no robust evidence in an acute situation. But as extensively discussed by Dr. Venkat, once you have treated the acute phase with low molecular weight heparins or unfractionated heparins, then to continue, one could possibly, but there are mixed sort of studies. Especially in this CKD, you would be little concerned about the NOACs. But we do use it for long-term anticoagulation as a changeover.
So oral continuation, if your renal functions are normal, can be an option in adequate doses. Vasopressor of choice, adrenaline versus noradrenaline versus dobutamine.
See, NORAD is always the first choice. Dobutamine, if you have got on to the stage where LV function is compromised with low cardiac output, so after ascertaining good volume status and after noradrenaline initiation, you would add in a trickle of dobutamine for that inotropic effect. But predominantly initially, it will be a very mini allocort with the vasopressors with noradrenaline. And then later on, after attaining some decent map, you would add in little dobutamine. But make sure when you start dobutamine, make sure that patient is in a euvolemic state and not in a hypolimic, because that can cause a lot of hemodynamic compromise.
Yeah, I think with the limitation of time, I think we crossed around 1 hour 56 minutes, and we still have 270 plus our dear students who are hanging on to listen to Dr. Pradeep Rangappa. And I thank Dr. Mahesh, who actually brought this case. I know it's very easy to be on the chat box and answering questions, but when you're on the real time being an examinee, it will be a different scene and scenario. So this is again a kind of an experience, like a live experience, how you feel when you actually face examiner and examination. So that's why we feel you need to get into a feel of that. So that's why we brought this some live discussions, live cases. And I'm being a part of the same organization. I didn't try to change one of his information, because let it be like a live regular ICU case, so that we will get into the discussions to differentiate and how do we go about. And I thank Dr. Pradeep Rangappa sir, who actually brought his all experience, wisdom, and his intellectuals and also his scientific knowledge into act to answer all your questions. And I know with this limited time and with these interactions, we may have left alone many gaps, but I know there always been it's not possible to cover all the areas. This is just to actually give you overview so that you can go back and probably refer to those all areas. There will be many questions which remained in your mind, and you at least get a hands-on experience kind of thing, how this case scenarios goes on. So I thank everyone who participated, and from next alternative week onwards, we will bring more cases. I think we have only released up to July, but we have another set of 30 cases which are ready, which will come up in the next maybe week or so. So we will come up with this all cases with all the examiners across India who will be participating us. So with this, I thank all the participants, and the final comments from Dr. Pradeep sir, and then will conclude the session.
Yeah, thanks, Venkat. I think you have encompassed all the salient aspects. So sincerely, I wish to thank all the listeners here who have very actively participated. Having 300 odd people sitting till 9 o'clock on a busy working day. I'm sure you've been working all day. And I wish all my future intensivists all the best, because you are the torchbearers of our specialty. And I wish to congratulate and wish Dr. Mahesh all the best. And I hear the NEET results are out yesterday. So I'm sure many of you will be scouting for the institutes that you would be desiring. So I wish each one of you all the best in the specialty of intensive care, and you are the torchbearers to take our society to greater heights to our specialty. Thank you, one and all.
Thank you, one and all, and I conclude the session. Thank you.
Thank you, Venkat.